I'm saying hello to everybody who is coming in. I'm very happy to say my warm welcome to you on behalf of the European AIDS Treatment Group, EATG. And as you may have realized, we have a region of Europe to cover that ranges from Europe to Central Asia region, because we are following the WHO idea of Europe. We are welcoming you to a web meeting that is full of acronyms. You already learned EATG for the European AIDS Treatment Group, and now you are learning the program's name, which is SCOPE, and this again is an abbreviation or an acronym for Strategic Community HIV Prevention Empowerment. And what we are going to learn today within the next 60 minutes is we learn about the development in the HIV and STI biomedical prevention pipeline. This already comes as a technical term, and I encourage all of you to be very alerted whenever you do not follow the language. Please use the chat and please use the possibility of asking questions, because this update is for you, for community educators and advocates, and we really want to make sure that you can follow all the important things our brilliant experts are sharing with us. You have already seen our housekeeping rules. We make you aware that this event is being recorded and shared afterwards. Please make sure that your mic is muted unless you want to be heard. You can ask your questions throughout the chat and especially throughout the Q&A session, Q&A question and answer. And if you have any technical issues, please send an email to Chiara, who is also visible on my screen next to me. Thank you, Chiara, for providing all the assistance here, and Apostolos, who is also screening the chat. So what is to be expected within the next 60 minutes? We will hear two presentations. Oh, well, I should probably introduce myself a bit more. My name is Harriet Langanke. I'm based in Germany, in Cologne, and I'm a sexologist and a journalist. By the way, you will find more about the bios of me and the CVs of our speakers in the chat. I am co-chairing EATG's program that's called Combination Prevention, which is that I am very proud to welcome you to this wonderful session. And you will later meet Amanita, who will help in moderating and facilitating this session. And you already have seen the names of our experts, Cindra Feuer and Verde Hashim from AVAC. And later on, we will meet Nichole Klatt and Lydia Ann Fein, both also from the US. A very warm welcome to all four of you. I was given 5 minutes. I promised I wouldn't take them all up. So it's 4 minutes past the hour, and I open up the stage. As I learned, Kat, you would be the first to present, and may I ask you to remind, as everybody else, to speak as slowly as possible, because our interpreters try to translate into Russian. Kat, the stage is yours. Thanks for being with us.
Thank you so much, Harriet. So just introduce myself. My name is Verde Hashim. I'm a program manager on the Product Introduction Access team at AVAC based in London. And I'm with my colleague Cindra Feuer today, and we are going to take you through the PrEP pipeline and promising prevention tools. So just a brief overview of what we're going to cover. I'm going to show you an overview of what the pipeline is, the products that are about either just coming to market or about to come to market. I'm going to go through each of the products in a bit more detail so you can understand what they are. And then I'm going to hand over to Cindra to speak to us about advocacy for prevention, research, and implementation. So first we have here an overview of the pipeline. So you can see across the top is a timeline, and I've shaded in red where we are right now, which is Q2 2025. So for each of these products, where it kind of crosses the red line, these are products that are currently available. And then further down where it's just approaching the red line, these are products coming to market soon. So available currently in limited context, we have the dapivirine vaginal ring, and we have 2-monthly injectable cabotegravir. And then further down, just coming to market, we have 6-monthly injectable lenacapavir. We have FTAF, daily oral FTAF for cisgender women, and the monthly oral pill MK8527. And then we also have, hopefully coming to market soon, the dual prevention pill. And I'm going to provide a bit more detail on each of these now. So first, oral PrEP. So I'm sure most people on the call are already very familiar with oral PrEP. It's a daily oral pill that you take to prevent HIV. We do have some new innovations that have come out of the CROI conference earlier this year that I wanted to share, particularly options for cisgender women. So there are 2 types of daily oral PrEP currently. The first is called TDF-FTC, also known as Truvada. This is the most commonly available type that you probably are familiar with. Now, currently with this product, you can take it every day consistently, or you can take it on demand. And on-demand dosing regimes up until now had only been indicated for individuals assigned male at birth, so cisgender men or transgender women. On-demand dosing means taking 2 pills 2 hours before exposure, 1 pill 24 hours later, and another pill 24 hours after that. So it's often called the 2-1-1 regime. Now we have new data that's, again, just came out of CROI showing that PrEP can still be highly effective for cisgender women using a modified version of this regime. So instead of 2-1-1, it's 2-1-1-1, so taking it an extra day, or 2-2-2-2. So this is very exciting because it means cisgender women will have additional options for how they can take their oral PrEP and have it still be effective. It hasn't been, approved or recommended by WHO yet, but we have the data now to show that they can review and hopefully recommend it. The other form of daily oral PrEP, the one that's a bit less common to see, is called FTAF. It's also known as Descovy. And now, similarly, this product currently is only indicated for individuals assigned male at birth, so cisgender men and transgender women. But recently, again at the CROI conference, we had new data from the Purpose 1 trial, which showed that FTAF should be considered for cisgender women. So it's great to see that there'll be more options and choice within oral PrEP, both products and regimes that will be accessible, hopefully soon for cisgender women. And I just want to make the point for oral PrEP just generally, adherence is important and protection increases with the frequency of pills. So something that we're always find across the board is the more frequently you take it, up to once a day, the better level of protection is. Protection starts to go down once you're doing 5 or fewer pills a week. Now moving into the long-acting injection, the long-acting options that are currently available. So this is injectable cabotegravir, or CAB for PrEP. It's the first commercially available injectable PrEP. CAB is an intramuscular injection given in the buttocks every 2 months, and it was developed by ViiV Healthcare. It's been approved in over 50 countries, including by the European Medicines Agency, which, just a reminder, the European Medicines Agency covers all approvals for EU countries as well as the 3 EEA countries, which are Iceland, Norway, and Liechtenstein. It's also been approved in the United Kingdom and in Ukraine. However, it's not currently widely available in Europe. There is a small-scale PEPFAR-funded program in Ukraine, although this is currently under threat due to the U.S. government funding cuts. One of the reasons it's not widely available is that concerns about cost have made some European government bodies hesitant to recommend it for use because it is quite expensive, especially in high-income countries. We do expect that once generics become available, these will be cheaper. Generics are expected in 2027, but the generics license within Europe and Central Asia only covers Georgia, Kosovo, Kyrgyzstan, Tajikistan, Ukraine, and Uzbekistan. This product, cabotegravir, has been shown to be superior to oral PrEP in trials, but this may be primarily because it helps facilitate adherence. So we know one of the challenges with daily oral PrEP is it can be difficult for people to remember to take a pill every day, the pill burden. You do not have this issue with a long-acting product. So that facilitating adherence means it can be shown to be more effective. As I mentioned, this is a 2-month product, but there is a 4-month version currently under investigation, and that could be available in 2027. So in a few years, we may have a longer acting version of this product. Moving on to the other long-acting product, which is currently available in some limited contexts, we have the Dipivirine vaginal ring. This is a flexible silicone ring inserted into the vagina by the user, which releases Dipivirine over the course of 1 month, and it was developed by the International Partnership for Microbicides. This is a locally acting product, meaning it has fewer side effects. It reduces the risk of acquiring HIV by 35 to 50%, and this is a bit less than we see in some other prevention products. However, what's important to remember is that the most effective product is the one someone will use. And a lot of people would prefer a locally acting product. So it is important to have these options available, even if on paper the number for efficacy might look a bit lower. Currently, the Dipivirine vaginal ring has been approved in 12 African countries, although it is not currently widely available outside implementation studies. There are no plans to submit it in Europe at this time, though it was given a positive opinion by the European Medicines Agency, which is not the same as approval. And a 3-month version of this product is also under investigation. So again, the version available now is 1 month, but there's a 3-month version being developed, which is under investigation. So those are all the products that are currently available, even though some of them are only available in limited contexts. The products I'm going to talk about now are ones that we are expecting to come to market soon. So the first one to look at is injectable lenacapavir, or LEN for PrEP. LEN for PrEP consists of 2 subcutaneous injections given in the abdomen every 6 months, and it was developed by Gilead, who were the developers of oral PrEP. So this is a 6-month version of injectable PrEP. It was shown to be safe and highly effective in 2 large phase 3 trials, and in fact, in one of these trials, Purpose 1, there were 0 infections amongst participants who were using lenacapavir, which is really amazing. That's pretty much unheard of in any prevention trials. And then the other trial, there were only 2 infections. So on paper, this is a highly, highly effective product. It's currently approved in limited settings, including in Europe, for use as treatment. But the first approval for use as PrEP, as prevention, is expected to come from the United States Food and Drug Administration next month, with other countries to follow. Lenacapavir was also submitted to the European Medicines Agency in February of this year, and we expect to hear a decision by the end of the year. Again, this product, coming out will probably be quite expensive, but cheaper generic versions will become available. There are currently 6 direct licenses for generics, and we expect the generics to become available in 2027. And the license for lenacapavir within Europe and Central Asia covers Armenia, Azerbaijan, Belarus, Georgia, Kazakhstan, Kyrgyzstan, Moldova, Tajikistan, Turkmenistan, Ukraine, and Uzbekistan. So in addition to this 6-month formula, which we hope to see very soon, the Gilead have been developing a yearly formula, so annual LEN, just 1 injection a year. Early data shows it to be safe and effective, and if further trials are positive, this annual version could be available as early as 2027. Next, we have the dual prevention pill. This is a co-formulated tablet or pill that combines oral PrEP and oral contraception into 1 single pill, and it was developed by Viatris. The DPP, or dual prevention pill, it consists of a 28-day regimen of 21 combined PrEP and oral contraception pills and 7 PrEP-only pills. It has successfully demonstrated bioequivalence. This means they've demonstrated that when you take the 1 combined pill, the drugs are absorbed into your body at the same rate as taking the 2 pills separately, the 2 pills separately at the same time. And this is what you need to demonstrate to show that it is, the same as the individual pills. It could receive regulatory approval this year, although the initial target market will be African countries, so we don't have any indication when or even if this product would be coming to Europe. If approved, this will be the first commercially available multipurpose prevention technology since condoms. And what we mean by multipurpose prevention technology is a product that deals with multiple health concerns. So in this case, it's preventing both pregnancy and HIV. And this could pave the way for other multipurpose prevention technologies. There are actually quite a few in the pipeline now that might prevent HIV and certain STIs, or pregnancy and certain STIs, etc. So it'll be very exciting to have the first one. The last product I wanted to show you today is called MK8527, which is a bit of a difficult name to remember, but you can remember it as the monthly oral pill. So this is a monthly oral pill developed by Merck, currently under investigation for use as HIV prevention. And it is also under investigation for use as a weekly treatment. Recently completed a phase 2 trial, which looked at safety, tolerability, and pharmacokinetics, meaning how the drug is absorbed into the body. And a larger phase 3 trial is expected to begin in the middle of this year. If this is shown to be successful and if approved, this would be the first long-acting PrEP in pill form. And you might think, this is a 1-month product. We have other longer products that are already available, 2 months, soon 6 months. But important to note that a pill is much easier to deliver than an injectable. And some people also don't like injections. So it's really important that we give people long-acting options that are pills, and this would be the first one. Now, just to summarize about when we think these options are going to become available. So as a reminder, what we have now, we have daily oral PrEP, we have 2-month cabotegravir, the injectable PrEP, and we have the 1-month vaginal ring. What we expect is that in 2027, there will be a lot more choice, and actually we call this a bit of an innovation pile-up, because in 2027, we expect to see generic versions of 2-month cabotegravir. That's like the less expensive versions. We also expect the 4-month version of cabotegravir to become available, the originator product. We expect that 6-month lenacapavir will have generics available also in 2027. And we're expecting that the 12-month originator product for lenacapavir will be available as well. So a lot in 2027. And then in 2028, 2029, we're also expecting to see that monthly pill from Merck MK8527 become available. And also hopefully by then it will have a proper name so we don't have to just refer to it as some numbers and letters, which are easy to forget. So that is it for my presentation. I'm going to hand over to Cindra now. And Cindra, I'll keep controlling the slides so you can just let me know what to change.
Great. Thanks so much, Kat. Sorry. Okay. Hi, everyone. Kat just walked us through a beautiful presentation of what's in research. And I'm going to talk a little bit about how to take that beautiful science and all those research innovations and get it to the people who need it the most. And that's, I think, possibly even more difficult of a task than the science, than doing the science. But before that, I also want to point out that there's more research happening than just PrEP. PrEP is ARV-based prevention. There's, as you know, there's it goes beyond that. So, Kat, next slide, please. So, the non-ARV based trials in Europe specifically, and when I talk about trials, I'm talking about efficacy trials, and these are the ones that are trying to prove proof of concept. So they're late stage, they're large scales, and if they work, then they move on to licensure. So just to sort of place it in Europe a bit, there's a lot of research happening in sub-Saharan Africa and in the US and some in Europe. And so far, what we've seen in Europe, we've had the vaccine. We had a very promising vaccine in Europe called Mosaico, and it was actually discontinued a couple of years ago because it was proving not to work. So that was happening in Poland and Spain. And then we had the AMP study was actually quite successful, and that was in Switzerland, amongst other countries. And that was an antibody where you get infused with an antibody to help prevent HIV. And that was a really successful trial that proved that infusion of an antibody will indeed protect someone from HIV infection. And now they're working on further research combination antibodies to see if they can get something that's marketable. And then as far as PrEP, ARV-based prevention research that's happening right now in Europe, there's the PURPOSE trial, and that's looking at the injectable len. And we already have proof, as Kat talked about, that injectable len works. There's a trial called Purpose 5 in gay men, MSM, in France and the UK. And these trials were planned and started before we had the trial results from the earlier purpose studies. So these are just going to be confirmatory efficacy studies. Next slide, please. So let's talk about research advocacy. Research advocacy is sort of difficult because research is done in the clinic, in the lab. So it's really hard for us as community workers and educators and activists to know what's going on in the clinic, in the labs. But there are mechanisms for us to get involved in research, especially if you're in a country that is doing research. And I just pointed out there's Poland and Spain and Switzerland and France and UK. And you could get involved with an actual research site that's happening. And in fact, it's required of the researchers to be, it's required by the good participatory practice guidelines and by UNAIDS ethical considerations that they engage the communities that they're studying. So if they have hopefully there's transgender people in their studies, and there's MSM and there's sex workers, and they need to build relationships and have these populations as part of their research teams. And that's upon us as communities representing key populations to make ourselves known and get ourselves into these processes so that we can help guide the research. As we say, nothing for us without us. Next slide, please. And so now there's advocacy for PrEP implementation, and I'm gonna probably just skip through these because Kat talked a lot about them. So I'm gonna go really quickly. Kat, next slide, please. Just the point that that the goal is that we have PrEP options, because right now, as you all know, there's oral PrEP. It's been available for probably 10 years. Well, it's been proven to work for at least 10 years. But in a lot of our countries, it's not being rolled out to scale. And in the places that it is being rolled out to scale, we see that people are having a hard time staying on it for whatever reason. They're not able to adhere, they're not able to take a daily pill every day, or they're not able to take it at the time of sex, before sex and after sex. And that's why we need more methods to protect ourselves. That's why we need injectables. That's why we need a vaginal ring. That's why we need, and there's all different other things being looked at, different insertions, douches, patches. That's why we can't just say, oh, we have oral PrEP, let's just stop. That's why we need all this other research. Next slide. So to focus on Eastern European and Central Asia, which sometimes gets overlooked, we need to build community networks of advocates to engage on a national level, the decision makers. That could be a technical working groups. Ukraine and Georgia have been models of PrEP, oral PrEP success. Now we need to work with those PrEP programs that exist and ready them for the injectables and get them ready for the monthly pill. And, you know, cost is definitely an issue. So we need to work with donors. We need to work with WHO priorities, the European regional priorities on these levels, on these high levels, and on national level to prepare for these new modalities. Next slide. I think I want to just run through because I realize these, and this is too much detail, but we'll share the slides with you if you really want to see the details of how to get involved in national and global level advocacy for oncoming injectable PrEP. Next slide. Next slide. Next slide. Sorry, I'm just jumping through because I'm aware of time. And going back to DIY, do-it-yourself prep. Thank you, Prepster, Will Nutlin, that whole team that originally helped facilitate the purchase of prep online. This is how everyone used to do this in Europe before there were prep programs, and that's still available. Dynamics International, if you're in a place that does not have an oral prep program, you can still get it online through this. And you can also go to Prepster. They have a lot of resources for how to access oral prep for now, and hopefully all the upcoming new modalities. And I'll stop there. Thank you.
Thanks, Cindra. And I'll just note we have some resources here at the end, which you can see once we share the slides. Thank you.
Thank you,
Thanks.
Catherine, and thank you, Cindra, so much for these two extraordinary presentations. I just noticed that we have an incredibly big public, like there's a lot of people attending. That makes me really excited. And so what we're gonna do now is that we're gonna have a 10-minute session of Q&A for questions. And well, I would like to see if there's any hands up, but if there's not, I actually have a few questions for both of you. So I'm gonna go ahead, maybe ask one or two questions first, and then see if we have hands up, if someone else wants to jump in. So Catherine, I'm gonna start with you, Kat. You were talking about the different ways that people can take PrEP, and this is being known as taking PrEP on demand or taking PrEP regularly, right? You just mentioned that recent research, it's pointing to for cisgender women to be able to take that PrEP on demand just as people assigned male at birth. Oh, did Kat? Oh no, there you are, Kat. As people assigned male at birth. But then my question is, does this apply to trans masculine people, to trans men and trans masculine people? And if it doesn't, or if it does, how do you know? And by that, I mean, what is, or was there a representative sample size of trans people, trans masculine people included in the research that led to those conclusions, or was this only done among cisgender women? And that's going to be my first question. I see there's already two hands up, so I'm just going to stop there and then going to let the other ones take over. But Catherine, go ahead, and then I'm going to pass it on to Enrico, to Igars and Enrico. Catherine, go ahead.
Great, and that is an excellent question. And unfortunately, the trial is only done with cisgender women. And I'm so glad you raised this, because this is something we see time and again with trials. You know, we often see inclusion of cisgender men, cisgender women, transgender women. Transgender men get left out all the time. They're like the least represented group. And they also have a big need for PrEP as well. So unfortunately, we can't make any statements about use of on-demand PrEP, you know, for trans men, but like that's where maybe advocacy can come in, that we need to get this information.
Thank you, Catherine. And that is the reason why it is important to include trans people in your clinical trials. Now, let's go with Igars. Igars, did I pronounce your name properly? I apologize.
You said it correctly. So very short. So one is for Catherine, and another one is for Kendra. Do I pronounce your name correctly?
Cindra,
Yeah.
but that's all right.
Okay. So I was just curious, Catherine, you mentioned 7 countries that have a voluntary license for cabotegravir. I mean, because you went through the slide so quickly, but so which is different from compulsory license, which means that the producers actually granted them some kind of rights. I'm curious about how these countries obtained, because the framework is that we still have these 2-track Europes. There's like wealthy Europe in the western part, which has already, as you said, almost like 10 years of experience with PrEP. And then in the eastern countries, like in Latvia, we had this sort of pilot project for PrEP that was financed by UK-based company, and then it ended. And right now, because the government wants to spend so much on defense, they just jacked up the 5% on defense, which means it's again going to affect all the health services. I just don't see how Eastern Europe, particularly the Baltic states, will implement PrEP in the next 5 years, realistically. And for Kendra, the question was if you could send a little bit more information about, I think you mentioned that community getting involved with these high level
Mhm.
on the high. If you could maybe give some kind of guidelines or something, send it to email later on, would be very helpful, because the way that very often the sort of initiatives being achieved in the Eastern Europe are still from the up down, not from the grassroots. We do participate, but if you have a strong sort of initiatives coming from the Brussels, then sometimes in Eastern Europe, that's the way things are achieved much faster, unfortunately.
Okay, perfect. Thank you. I'm going to pass it on to the speaker.
Thank you. So for your question about the licensing, so the voluntary license for cabotegravir was negotiated through the Medicines Patent Pool. So the coverage is based on what they negotiated, and just in general, you don't really see high-income countries ever covered by those licenses. It is mostly low-income and middle-income countries, and it has to do with all kinds of local patent rules that are a bit above my knowledge, unfortunately. But it is a really great point that you know, generics should be more widely available. Yeah, pass to Cindra now.
Great, and thanks
Cindra?
for that. Sure, can you hear me? Yes. Thanks for that question. It's really important that these higher level conversations happen and with community, with civil society who needs them. And there are a few mechanisms like UNAIDS. There's a need for UNAIDS. And I know that there was UNAIDS in country, and we know that they're being slashed now, thanks to the US. But getting UNAIDS, getting the companies like Gilead and ViiV to the table with the donors, whoever that might be, whether it's still Global Fund, and civil society and communities, healthcare providers, advocates, and policymakers to sit at the table and work out work out some regional plans. So globally, there's a global coalition for long-acting injectables that's working with UNAIDS, and I'll send you the information for how to have access to that.
Great,
But yes, go ahead.
No, I said thank you. That would be really
Sure.
Okay, thank you, Catherine. Thank you, Agars, and thank you, I'm sorry, Cindra. Enrico, go ahead.
Thank you. I did a question for Catherine, as I think you mentioned two different schemes for cisgender women, 2111 and 2222, which I hope means what they seem to mean. But my question is each of these two schemes is suggested under specific circumstance, specific condition, or if they are equivalent, but since one involves taking more doses, I think they are not equivalent. Thank you.
Sure. Yeah. So that's a great question. So neither of these are recommended at the moment, but what we know coming out of the CROI conference was that the 2111 scheme showed 84% protection for cisgender women, and the 2222 scheme showed 95% protection. So the 222 does have higher protection, but again, none of these are recommended yet. This is just based on the data we have, and then it will be up to, you know, WHO to review the data and see what they also recommend.
Okay, thank you very much.
Thank you, Enrico. And one final question, Eliane, would you like to go ahead? Or Eliane, I'm sorry, I'm not sure.
Yes. Thank you. I have one question on the dual prevention pills, DPP. Is it going to already started on some on a trial already, or is already done? And there was also dapivirine 0.2 that was supposed to be prevention and pregnancy and HIV. I remember Cindra before, she presented that on the pipeline. So does it mean that this pill is going to replace that dapivirine, or they are both going to be rolled out? Thank you.
Sure. So for the dual prevention pill, because it's two already existing and approved products, it doesn't have to go through the same kind of trials as like a new product like say lenacapavir. So the only trial they had to do was that bioequivalence, where it shows if it's absorbed into the body at the same rate as when you take the two pills separately, and that it passed that. So they're able to use that data now, and they're submitting to some regulators to see who can approve it. For the dual purpose ring, that actually it's further up the pipeline. So we don't, that's, you know, if it's successful, it'll be quite a few years in the future. There was a project that was following up on all these new multipurpose prevention projects called Matrix, but it was funded by the US government. So unfortunately, it had to be terminated earlier this year. So I'm not sure what the latest is, unfortunately, on that research, but it's a lot of it relied on US government funding.
Perfect. Thank you so much for the questions from the public. And now we are going to move on to our next session. The next session, it's going to be led by both Dr. Lydia Fein and Nichole Klatt. So we're going to start with Lydia. Please, Lydia, go ahead.
Hi, good morning, everybody. Thank you for having me. My name is Lydia Fein, and I am a gynecologist at the University of Miami in Miami, Florida, in the United States. And I provide gender-affirming care. I provide a full spectrum of care. I provide hormone therapy, and I am also a surgeon. And until June of 2024, when my institution required me to stop performing surgery, I was performing gender-affirming surgery. I also do research in this field, specifically looking at HIV prevention or risk of HIV in transgender women who have undergone vaginoplasty, and looking at some of the risk factors around vaginal transmission of HIV in trans women. I do this work in collaboration with Dr. Klatt, who I will turn our presentation over to in just a few minutes. So just to give some background, we traditionally think about gender in a very dichotomous way, where everything is either man or woman. There's certain gender roles, certain colors that we associate with each gender. But in recent years, we realize that gender is really on a spectrum, and we have many gender identities that we must be aware of, especially as we're providing care and working towards things like HIV prevention. So gender identity is really an internal sense of whether you are man or woman or somewhere along that spectrum. And all of these factors, whether it be sex, so the chromosomes or anatomy, your internal sense of self, which is your identity, all of these coalesce into each of us. And gender development is very complex, but it's multifactorial. So there's many things that go into one's gender, which highlights why it's so important to study different genders in different ways. So thinking about cisgender women or men differently than transgender men or women is something that's very new in terms of research in recent history. But the fundamental differences in each of those genders, as all of these things come into play, are very important and highlight why it's so important. Additionally, transgender folks face additional really health risks simply by being transgender. And this comes from a fundamental of the minority stress theory, where kind of existing in society as a minority, whether it be racial, gender, etc., you have an underlying stigma that that you kind of walk around the world with, that leads to oppression and psychological distress. But in trans folks, what this does is it really increases the need for gender affirmation. And sometimes at the same time, there's a decreased access to this, as highlighted, as you can see now, especially what's going on in the US, where we're really restricting access to what I consider to be, and many do, life-saving care. So when you have this identity threat, it leads to high-risk circumstances that might lead to HIV infection, such as exchanging sex for money, or drugs, or just unsafe circumstances. So while gender affirming care and access is really just the concept of ensuring people are respected and affirmed in their gender identity. For many trans folks, this also takes the shape of gender affirming hormones and gender affirming surgery. And this further highlights why we need dedicated research in this population, because we have two sides. We have the minority stress side, where when we lack gender affirming care, we have these health disparities that present a whole host of risks, and we need to learn how to address these risks in these folks to prevent things like HIV. But we also, on the other side, have when transgender people do access gender affirming care through hormones and through surgery, and what risks do those things confer? In the example of the research that Dr. Klatt and I do around the neo-vagina after surgery, we just don't know the answer to that question, and that's what we've been trying to study. So it really highlights the need for research, especially HIV prevention research in this community. So the Institute of Medicine has highlighted a few areas in which we should focus transgender research. So life course in terms of longitudinal studies. Our field is very young, particularly for us in the US. We don't have the benefit of, well, Europe is decades ahead of us in terms of providing this care, but we don't have the benefit of nationalized healthcare data. And then other things like the minority stress theory, as I discussed, intersectionality in terms of gender confluent and how it coalesces with race and other factors, and then just the social ecology context, which is particularly relevant for us now because our transgender populations, for example, in the United States, are facing an undue burden of lots of legislation and things like that. So one of the challenges we face is how can we properly define gender identity, because there's so many genders. We want to be sensitive and ensure that everyone feels included, but we also want to be rigorous and make sure that we're not presenting too many choices, which can be ultimately confusing and challenge our data analysis. So the NIH had actually proposed this schema for when you are doing research about trans folks to have a two-step question. One is to identify sex assigned at birth, and then the other is to define your current gender. This, with the inclusion of a free text option, this allows for to be inclusive, as well as reducing your risk of false positives, and allows for better data analysis. So this is generally what we follow. Other things that are very challenging is the fear of stigma and mistreatment, disclosure and privacy concerns. So one way that we address that is through the Community Advisory Board. So we incorporate and engage the transgender community and local organizations and all the work that we do. And it really helps create a sense of trust among our research participants and makes people feel safe to engage in research. Another issue is sampling. So the trans population is a relatively small group, but that just shouldn't be a deterrent. We should all data are important when we're because we have so little of it. And then sometimes specimen collection, particularly among trans folks who might have a lot of sensitivity or a lot of distress around things like their genitalia. So we recommend self-sampling of things like STD swabs whenever possible. So I'm going to highlight now the study that Dr. Klatt and I have worked on together, just to focus a little bit more on one way that we're addressing HIV risk, assessing HIV risk in transgender women who have undergone vaginoplasty. And in the next slide or two, just fair warning, I do have a slide with some pictures of genitalia on it. So just be warned. I'm a gynecologist, so I had to. So this is so important because trans women are at extremely high risk of acquiring HIV. In some populations in the US, in some cities, the HIV rate among trans women is as high as 40%. So along with that, one of the gender affirming procedures that we can do. And if you think about the minority stress theory, this can really mitigate some of that stress and potentially lead to safer, to lower HIV risk, is the vaginoplasty. It's a highly desired procedure, and it's a genital reconstruction to turn masculine genitalia into feminine. It's a highly desired and highly undertaken procedure, but what we don't know is the risk that is conferred by this procedure by creating the neovagina. We make it usually out of skin and sometimes other tissues. So that's a question that was unanswered. We know that in cisgender women that the microenvironment and within the vagina is very important for the risk of HIV, so the bacterial composition. But we don't know how this translates into transgender women. So this study the goal was to characterize the microenvironment of the neovagina to better understand HIV risk in trans women after gender-affirming vaginoplasty. So I'm going to turn it over to Dr. Klatt to talk a little bit more about this.
Thank you so much, Lydia. Nichole, you can go.
Nikki, I think you're still muted.
Yeah, there you go.
There we go. Okay, sorry. Thank you so much for the invitation to speak today, and thank you, Lydia, for that brilliant introduction to this work. So I'm going to take it back just a second because I'm going to throw some science at you here. So I'm going to go over some terms and kind of give you the background of why we're looking at the biological mechanisms in the transgender woman. So just to make sure we're all on the same page, you've probably heard of the microbiome. You've probably heard you have to eat your yogurt and you want your good bacteria. So there is more bacteria cells in your body than there are human cells. And these are extremely important for developing health and disease processes. And there's multiple microbiomes from, the gut is the biggest one, but all of your body, your skin has one, your mouth has a microbiome, your nose has a microbiome, your vagina has a microbiome, and the neovagina has a microbiome. And when we talk about the microbiome, it's not just bacteria, but there's also viruses, fungi, protists, and archaea. I'm going to focus on bacteria for this talk today. And then also it's important to mention that they are very metabolically active and includes genes, metabolites, and products that these bacteria can make. And I'll touch on this and the metabolic activity of them shortly. I want you to know the word dysbiosis. I use that a lot. And dysbiosis is when there's an imbalanced microbial community. And this can be either an imbalance in abundance of the microbes or functional changes to the microbes. So I was going to say this is the Klatt Lab slide of how we approach science and understanding metabolic biological mechanisms that underlie health. And so there's this microbial dysbiosis that occurs and can lead to dysfunction in mucosal immunity and systemic inflammation, and then immunity and inflammatory responses throughout the body. For this talk, obviously, we're focusing on women's health, or transgender women's health. So this is a cartoon of putable mechanisms that can underlie increased HIV transmission. And this is from cisgender women, but this is very applicable to transgender women, and we will come back to that. I'm just using some of the data that we've already done in my lab from cisgender women to kind of lay the stage here. But basically, when you have a healthy female reproductive tract, you want a nice intact epithelial barrier, and there should be homeostatic cells and cytokines that support this barrier. And then what we really want is a healthy lactobacillus dominant microbiome. However, in the context of when damage goes awry here, you have breakdown of the mucosal barrier. You have pro-inflammatory cells and cytokines that overcome those homeostatic ones, which means that you have inflammation, and that can further perpetuate breakdown of that epithelial barrier and then allow viruses and pathogens to cross. The pH can be altered. It's really important to have a very low pH in the vagina. And that's one thing in the neovagina that we know is it has an increased pH. And this is likely due to an altered microbiome where you get these polymicrobial anaerobic species. So what is bacterial vaginosis clinically? It's highly prevalent inflammatory vaginal disorder. Symptoms include vaginal odor, discharge, itching, burning, but it also can be asymptomatic. Increased risk of pregnancy complications, STIs, PID, and it's treated with antibiotics, metronidazole mostly, but you have about 90% recurrence after a year. So these antibiotic treatments do not work in it. And the risk factors and pathogenesis are poorly understood. And this is important both for understanding this in cisgender vaginas as well as in transgender neovaginas. So just to give kind of that 30,000-foot view of what this is by a cartoon. So like I said, you want a low pH in the vagina and you want dominance by lactobacillus, and this helps drive that low pH because lactobacillus actually makes lactic acid, which keeps that pH very low. So you would have a Amsels or Nugent score that if you're a woman, you've probably gone through at some point, where they take a slide like this and look, there's not many cells and you can see lactobacilli, you have a nice low pH. But when you have bacterial vaginosis or dysbiosis to the vaginal communities, what happens is you get these polymicrobial species. So you get multiple species, not just lactobacillus. And these tend to be anaerobic bugs, and these drive the pH up, and they can directly drive inflammation and barrier damage. And then when you look at the Nugent score, the Amsels criteria here, you see a lot of these clue cells that come in, and you see a lot of polymicrobial bacteria at a high pH. So how we look at this scientifically is like this. This is from the FRESH cohort in South Africa with Doug Kwan's group at the Reagan Institute. And when we look at these data, each line is an individual woman. These are cervical vaginal lavages from individual women. Each line is a woman, and each color is a different bacteria. So in these early slides over here, you have just lactobacillus dominant. This is like the CT1 is lactobacillus dominant. So that's what we want. That's the good vaginal microbiome. But as you get into this more and more diversity of the vaginal microbiome, that's when things tend to go awry. And you can see this here by looking at the rate of HIV infection in those women, where if you have that lactobacillus microbiome and CT1, there was 0 cases of HIV infection in those cohorts. However, as that diversity increased through the different community types, then the risk of HIV infection increases. And again, even in meta studies, time and again, we show the bacterial vaginosis and HIV acquisition are tightly linked. So HIV acquisition is highly associated with having bacterial vaginosis. This is also important for PrEP. So going back to the first talks, we talked about the PrEP. Well, this was in Caprisa 004, which was a study of tenofovir gel that was placed intravaginally. And what we did is we took cervical vaginal lavages and looked at the bacteria in the cervical vaginal lavages from women in the study. And while the overall study efficacy was 33%, which is really abysmal, the studies of PrEP in men are much higher, but in women, they're much lower. So it's 33% overall, and that was considered a win. However, when we break it down into women who are lactobacillus dominant on top or non-lactobacillus dominant on bottom, this efficacy changes. So if you have lactobacillus dominance, that's that good optimal bacteria, you have 61%. But if you do not have, if you have these polymicrobial bacteria, your efficacy goes down to 18%. So this is the first time we've shown that the bacteria in the vagina can actually directly affect PrEP efficacy. We later on want to show that it's not just tenofovir. But when you have dysbiotic bacteria compared to healthy bacteria, you lose these bugs this is direct metabolism by the bacteria. So the bacteria are actually eating the antiretroviral drug and metabolizing it to products that are not used for HIV infection. And this occurs in tenofovir, it occurs in dapivirine, the dapivirine ring came up, it can occur in dapivirine, and we did not see it so much in TAF. So there is some good news that we might not see it. And these are for intravaginal, by the way. The jury's kind of still out if this affects oral PrEP. But it is something that we need to really take with grave concern. So in moving over to the transgender health then, and what we know about cisgender health and bacterial vaginosis, how we can apply this now to HIV risk and transgender health. So as Lydia talked about, we did a study. So there was 10 transgender women in the study that had neovagina surgery 3 years out. And then not only did we look at multiple components of intervaginal practices and estrogen levels and progesterone levels, et cetera. But one of the things too that I want to highlight in these data is that we also looked at the how many partners they had and what kind of sex they were having and with or without condoms, and made into categorical mean variables that I'll talk about. Sorry, I'm just
Nikki,
moving my...
5 minutes.
Yep. So right away, here's the different bacteria groups. And so remember, one line is a woman, and then each color is bacteria. So what you can see from all of our transgender women, and these are grouped into that above mean or below mean. So above the mean of how many people they've had sex with, or below the median of how many people they've had sex with. And so this is multiple partners on the left and less partners on the right. But what you can clearly see is that you don't see this lactobacillus dominance at all in the neovagina, that there's polymicrobial species in all of them. So it's more like a BV state. So what does this mean for inflammation? And I'm not going to go into the details of all of this, but basically, so when we look at inflammation, I'm sorry, this should actually say IL-8. There's significantly more inflammation with IL-8 in women, transgender women who have multiple sex partners, significantly more multiple sex partners. IL-1 beta, another inflammatory cytokine, we see the same thing. When we put in the different sexual partners in the past month and vaginal sex acts in the past month compared to these different cytokines in this box here, the blue is actually highly correlated. And what you can see is there's tight correlations between the sex number of sex partners and number of receptive vaginal sex acts in 1 month. So the sex can directly alter the inflammatory profiles in the vagina, in the neovagina. So we want to also look at this in terms of differential abundant bacteria. And I'm not going to get into the specific bacteria, but what you can see is there's changes in the bacteria compared to women, transgender women that are above or below the sex partners. So if you have a lot of sex partners, you have increased Gamella relative abundance, and same thing with fusobacteria. I'll note here fusobacteria is associated with many inflammatory diseases and cancers. So this is a bug that you don't necessarily want in your vagina that is coming up with increased sex partners. So, and then another one, Streptococcus, is also increased. So then when we go back to these plots of looking at the correlation plots, when we look at different bacteria here, and again, we see some lactobacillus, but the lactobacillus is associated with different cytokines. So these are the cytokines they're associated with up here. Those are those inflammatory molecules, and then the bugs down here. And what you see is there's multiple bugs here that are associated with inflammatory cytokines. So this driving these different microbial features here might be driving the inflammation in the transgender vagina. So finally, just want to go back to this. So now, while this was an example of a cisgender vagina, these things all play a role in here in the neovagina as well, where you have an altered microbiome, we have increased pH, likely increased barrier trauma, which is something that we need to study better. And Lydia and I are trying to, and difficulties obviously with this administration, but it is our goal. And then increased pro-inflammatory cells and cytokines. And so really this cartoon here applies to the neovagina as well, only this is more of the natural state of the neovagina. So understanding the biological mechanisms to get it away from a state like this and into a more healthy state where you have a better microbiome and less pro-inflammatory cells and cytokines and barrier damage, and less ability to metabolize antiretroviral drugs is the goal. So to conclude, in BV and cis vaginas and in all neovaginas measured, polymicrobial anaerobic communities dominate the microbial communities. Dysbiotic vaginal and neovaginal microbes are associated with inflammation and could lead to increased HIV risk. Increased sexual partners in transgender women are associated with increased dysbiosis of microbes and with increased cytokine expression, potentially a biological mechanism of increased HIV risk. And more studies to fully understand the biological mechanisms underlying increased HIV risk in transgender populations is really critical. So just thanks to my team, especially Courtney Broadlow did a lot of this work. And then of course, Lydia, who is my partner in all of this, and happy to take questions. And thank you all for listening.
Nikki, this was, to both Nikki and Lydia, this was an extraordinary presentation. Thank you so, so much. I am learning so much, and as a microbiologist and as a trans woman, this is just like better than porn to me. Now, we're gonna go with questions. We're gonna start with Igars. I also have a question. I'm gonna take this board, but just to let everybody know, it is 1 minute to 4. So we're gonna stay a little bit longer. We're gonna stay until 10 o'clock, and that's sorry, not 10 o'clock. 410. Yes, that makes a lot more sense, right? So we're going to start with Agars. Agars, please go ahead.
Thank you so much, Nichole, for your excellent presentation. Very quick question. The issue of displaced microbiota is relevant not only to transgender people. Generally, that's considered everybody who's HIV positive, because there's something about HIV, it definitely damages the intestines. But then they sometimes online sort of recommend to use these daily use of probiotics. You buy them in pharmacy pills. In your clinical practice, do you think it's only hype, or do they really have a sort of somewhat modifying positive effect? Or because sometimes I have HIV positive people asking me these questions, should they spend money on these probiotics that tend to be expensive?
Yeah, so it's a really good question, and I do want to give the disclaimer that I'm not I'm a PhD, not a clinician, so I'm not an MD, so I do not see patients, and so I can't talk on to that aspect, but Lydia can certainly comment. From my bearing though, so I actually have done studies in probiotics in non-human primates. That we did a big study, and we did find that there was slight changes where in SIV infected non-human primates, we saw increases of CD4 T cells in the gut. That helped. And then they did a lot of ACTG trials here in the US with probiotics, but they really didn't see a whole lot. So unfortunately, I'm not sure that there's massive effects, but there could be slight alterations to the microbiome and decreased inflammation with continued use of good probiotics. And now, is that enough to really make up for the damage done? I don't know. What I will say though is that that's in the context of HIV infected individuals. In the context of prevention, I think that trying to find, there's live biotherapeutics, for example, like Lectin-V is having some promise, that trying to get live biotherapeutics that as suppositories into the vagina or into the neovagina to try to change those communities. And we're trying to figure out though the best way, because a lot of times they just don't take well and they don't colonize. So one of the goals of my lab is trying to develop basically like probiotic douches, for example, where we can, give a healthy douche that has the precursors that you need to have a better bacteria community, and let those survive. And then hopefully we get increased or decreased HIV risk there. And Lydia, I'll let you comment further on as far as if you'd recommend people taking probiotics from a medical standpoint.
Yeah, so in the average or healthy person who doesn't have recurrent vaginosis or some other thing, we typically don't recommend that, because we tell patients the vagina is a quote unquote self-cleaning oven. So there's the mucosa really does that job for you. Anecdotally, I've seen benefit from some women who have recurrent vaginosis, recurrent yeast infections, and they will start a probiotic. I try to encourage the vaginal probiotic. So I think that makes more sense. And they do report improvement, whether that's placebo effect or not, I don't really know, but I tell them there's not much harm in trying, but it's not, I don't think the evidence is there to suggest, any certainly routine use or using that as like a treatment modality or real prevention modality. So, I can try it, but it may or may not work.
Thank you so much to Lydia and to Nichole. I'm going to add something really quickly in this conversation, and then I'm going to pass to the next person who had their hand up. So one of the things that we need to keep into consideration in here is that for transgender people specifically, it's quite different due to the very different hormonal content, right? So for trans feminine people, we have way higher hormone levels, way higher estrogen levels often than even cisgender women, and we reduce our testosterone levels so drastically that it's often quite lower, even lower than for cisgender women. Now, for the case of transmasculine people, taking testosterone levels can also affect drastically the tissue of their genitals. And then for this reason, like a lot of these tissues come up, right, Nikki? And then specifically, actually, I will let the other person talk, but then I also would like to ask a question in regards of how all of this is affected, because if you're going to put probiotics in an environment that is going to be hostile for the probiotics, in a really basic environment
where if you're going to put a bacteria like lactobacillus, which will thrive in acidic environments, well, will that really work, or would you actually have to address the pH of the genitalia before adding the probiotic? That's one question. But then first I'm going to I'm sorry, I do not know how to pronounce your name. Can you please come into the microphone? Vladimir, can you?
I think it's Angelica.
Здравствуйте, всем добрый день. Меня зовут Анжелика, я из Республики Беларусь. Я трансженщина, я хотела бы уточнить такой вопрос. Если мы говорим о вагинальном дисбактериозе как одним из факторов развития ВИЧ-инфекции, почему это не может быть включено в какие-то клинические протоколы Всемирной организации здравоохранения? Или это наблюдения, которые делают врачи, которые вот только что говорили в презентации? Вот у меня такой вопрос.
Nikki, Lydia, did you get that?
It wasn't translated.
Yeah.
Oh, okay.
Yeah,
It's
I used
Vladimir, just a second. It's because I think Lydia and Nichole, you need to go into the interpretation and select interpretation in English so you could hear that in English.
Oh.
Can
Yeah.
the translator just translate first briefly what it was?
Да, повторите, пожалуйста. Мне надо его еще раз повторить?
Vladimir, yeah.
Да.
I don't know how to go into translation here for the sake of time.
Yes, I can hear you. And if Nichole and Lydia, can you hear him now?
No.
Okay, so you need to go and select the interpretation in English, both of you. Otherwise, Vladimir, you can ask the question to me and I can ask the question to Lydia and Nichole. You can tell me a question.
I don't know where to select interpretation. I'm sorry.
I'm sorry. I don't know where I'm doing this. Oh, here, interpretation.
Okay, so the question is, if probiotics are such an efficient way to treat bacterial vaginosis, then why is it not recommended by different medical guidelines like the ones provided by the WHO? And why is it not something that medical doctors are currently prescribing to people, to patients? Now, I'm going to let you answer that question.
Yeah, I think that was Lydia's point, though, is like I wouldn't call it an efficient way to treat it. I think there's some anecdotal evidence that there can be help, but I think that we are not to the point where we know how to effectively treat it. So it's, for example, like we've been talking about doing combinations because exactly like you said, Amanita, like you might need to first address the pH because you can't put these probiotics in a hostile environment. There's also, drugs given to increase mucus, and we have to understand how that mucus interacts. We have to understand, the bacteria also highly susceptible to changes based on hormone therapy. So we have to understand the hormones. So I think there's a lot more to understand of the biology before we're at the point of really prescribing probiotics. So that's something that, again, we're trying and work together to understand better so that we can develop better interventions. And Lydia, if you want to comment further.
Спасибо.
Lydia, would you like to talk?
Yes, I agree that the data just aren't strong enough to make any clinical recommendations, but it's something that official guidelines, but it can certainly be discussed with patients on a case-by-case basis.
Perfect. Thank you to both of you. Yeah, just basically wanted to close with how incredibly important it is to have access to this knowledge, both from TGEU, but also the same way from the SCOPE project and from the NGO delegation. We are currently really trying really hard to advocate for funding to go into research that is including trans people and all the key populations within the different clinical trials, within the different pipelines, and within the research that is currently being done, because without including us, you will never have a clear idea of what is the biomedical needs that we have and the ways to solve them. We have 10 minutes close. This is I'm gonna end the conference here. Thank you so much everyone for attending here. I hope your questions were answered. I hope you learned something new today. I know I did. Thank you so much, EATG, for organizing this. Thank you so much, Harriet, and thank you so much, Kira, especially you. You have been such a great leader behind the organization of this event. Thank you to all the speakers, Nikki, Catherine, Lydia, and I know I'm missing one person, Cindra. Thank you so much for being here, and thank you everyone else. Have a great day. Goodbye.